My name is Phyllis Silman, and I'm pleased to have here to chair together with Margaret Walton-Roberts, to share the webinar number 15 on the recruitment of international healthcare personnel, comparing conditions and realities in Germany and Canada. And we did so because Margaret and we think there should be more focus on a comparison between Canada and Germany, as both countries are reviewing at the moment their migration systems. And we thought one of the most important sectors is the healthcare sector we see. So this is why we are coming up with that webinar today. And we are very pleased to see you here. So this is the NUPS, the Networking Unit Paradigm Shift at Berlin Technical University, and that's Margaret. Margaret, maybe you say hello to our guests also.
Yes, hi, hello. I'm Margaret Walton-Roberts. I'm a professor at Laurier University, and I'm very happy that we have this opportunity to share a webinar looking at the German-Canadian experiences with the immigration of healthcare professionals, particularly. This is of interest to Felicitas and I and many of our colleagues. We have different research projects looking at this issue from various perspectives. I'm located at the Balsillie School of International Affairs in Canada, which is part of Wilfrid Laurier University. And we have been engaged in a research project looking at the migration experiences of nurses coming to different countries, including Germany, including Canada. And so we thought it was time to have an opportunity to have a deeper engagement and discussion about some of the policy shifts that have occurred, especially in light of the COVID-19 pandemic and labour force shortages that have emerged.
Mm-hmm. Thank you, Margaret. So what is our topic more precisely in here? Yeah, that is it. So if we see both Germany and Canada, we see similar challenges in terms of skilled worker shortages. Both countries have marked regional differences in the way migration and credential assessment is processed. So that would be one point. But then we had for a long time the Canadian model seen as to be the gold standard in some way, so the most innovative approaches to immigration worldwide. But we might question this. We might ask, is this still adequate? What can we learn by comparing two advanced migration societies? Because also Germany came up with reforms and now is a fully fledged immigration society. We compare this situation in respect of the healthcare workers, and here we look on regulations as well as on the lived realities that have evolved in Germany and Canada. So we thought we have a focus on the regulations and what healthcare workers experience. So that is the most important point of our webinar, so theory and practice. I'm pleased to start with some general observations on the two migration systems. And I think it's good to be aware of that we speak of two very different situations. So first, when we look on the way migration is treated on the labor market, for Germany, we can surely say that migration has always been the exception when it came to regulations on what migrant work means for the German labor market. So we had the guest worker system of the 60s, which ended in 73. And since then, we had only a special access for certain selected groups. So migration was also merely seen as an economic project. So this is a situation which holds true for Germany until 2 or 3 years ago, when we had the first law on the recruitment of skilled labor. We had always the exception. While for the Canadian situation holds true that it's been always a normality on the labor market to have active recruitment policies. So we have the temporary foreign worker program since the 70s. We have federal skilled worker programs and so on. So there's not the exception, but the normality. The next dimension would be the cultural dimension. This differs very clearly. Germany is a country still today with a somewhat, I wouldn't say underdeveloped, but with a small or a little welcome culture, while Canada is the country of an official policy of multiculturalism. This is tied to the German history, where we saw a strong xenophobic outburst in the first 50 years of the 20th century, of course, but this still holds true for parts of our society until today. So we have only now starting a big debate about racism and about a missing welcome culture. While for Canada, this impetus on multiculturalism is in the core of being a Canadian citizen. So the support of immigration is part of the society, at least at the rhetoric level, I would say. And yes, racism also exists in Canada, I would say. So, but this is for the Canadian colleagues to speak about that maybe, but we have to keep this in mind. So do we have a missing welcome culture? Do we have a fully developed welcome culture? And does it mean there is less racism? I wouldn't know. The mode of regulation is different. Even though both countries aim at having a reform of the migration systems, we see big differences. For example, Germany only now starts to bring in a point system, and Canada is doing this since many, many years. So that would be interesting to see what the differences are here. The next and the last point is about humanitarian access of people to the countries. So the humanitarian dimension. In Germany, we have, especially so since 2015, we have lots of refugees, more than 1 million Syrian refugees only in 2015 to 2017. While we have in Canada very few refugees. We have 25,000 refugees a year, more or less. That's the number. So this is a big difference when it comes to the whole of the migration system. And here I want to stop, but you can see there are marked differences, and we have to keep this in mind when discussing later the differences between the two migration systems. I hand over to Margaret.
Great, thank you, Felicitas. And when we then zoom into looking at this in particular occupational sectors, looking at the healthcare workers that are of interest to both Germany and Canada, what we need to understand is how this occupational group has been impacted by the COVID-19 pandemic and by more widespread shortages that have existed before the pandemic but have been intensified. And so just looking at the example of Canada, but I imagine many of this might be relevant to Germany as well, we have seen an acute pressure placed on health workers during the pandemic. And as a result, we're now seeing hospitals across the country be temporarily closing their emergency rooms, working short-staffed, changing their ratios of care. These haven't necessarily returned to pre-pandemic levels at this point. Statistics Canada has also revealed that 1 in 4 nurses is considering quitting the profession. So this is going to have a longer term impact on how we staff our healthcare systems. There is a concern about poor working conditions, abuse, low pay, and fatigue from overwork. We also have in Canada recognized that our ability to understand what is happening in the health workforce is compromised. We have a sporadic and ad hoc approach to data collection and understanding these shortages and planning for them. And so this is something our panelists will reference. And all of these things have come together to cause great concern across the country, but what we have seen is actually some responses from regulators. And so one of our presenters will be looking at this in more detail for one of the provinces, Nova Scotia, but we can also see in one of the largest receivers, Ontario, that new approaches, new policies, new models are being rolled out. This includes what's called the Supervised Practice Experience Partnership. And so understanding how these levers have been moved by the current condition in terms of policy responses and changes is part of what we're interested in this webinar. Thanks.
Great, thank you, Margaret. I'm taking over here. So we have invited 4 speakers, 2 from Germany and 2 from Canada, to speak about this setting we see at the moment. And we have invited David Kipp, who is a member of the German Institute for International and Security Affairs in Berlin in Germany. Thank you, David, for being with us. They were revising the new strategies for the recruitment of skilled labor, which is coming up now in the ministries, or which is tweeted at the moment. And we have invited Dr. Maria Kontos from the Institute für Sozialforschung in Frankfurt am Main. She's a long-standing scholar on the way healthcare workers live and work in Germany. So we are very pleased to have her here. And she will illustrate a bit what is going on for the workers on the ground, we could say. And we have then Ivy Bourgeot from the Faculty of Social Science at the University of Ottawa in Canada. She will speak about the regulations we see in Canada at the moment. And we then have Dr. Caroline Chamberlain-Dwyer from Nova Scotia Healthcare. Margaret just said this a moment ago. She's speaking about what does it mean for the people on the ground. So thank you, all the 4 speakers, for being with us. And we will have, after your presentation, time for discussion. Everybody's invited to put a question into the chat or to ask directly. We have very good experiences in working together in a loose form, and we will not record the discussion, of course. Thank you so much. So I would invite David to be the first to come up here. Thank you.
Thank you. Thanks for the invitation. I'll just quickly share my screen. You can see it now.
Perfect.
So
it works.
Okay, so let me start a bit with the outline of my presentation. I should mention beforehand that I think I'm, compared to the other speakers, not really expert on the question on the health migration, migration of health professionals. This is, of course, a very dynamic field in Germany that we also looked at. So I'll try to mention it as much as possible, but I'll rather give you a short.
David, would you have a headphone, something, because it's very hard to understand you.
Sorry. Let me see. Is it better now?
Yeah, much better.
Okay.
Okay.
Okay. So I was saying that I'll certainly also touch upon the health sector, but since we just came up with a study that I'm also going to share in the chat now, because it got published today in English, so I have to do that.
Perfect timing.
Yes, I will certainly touch upon that, but give you more of a broad input. And I'll have 10 to 15 minutes, I think. So like many other countries, Germany is, as you already pointed out, confronted with aging and shrinking demographics of its labor population. There are, of course, different calculations about how deep is the structural labor shortage. The Institute for Employment Research of the Federal Employment Agency predicts that the current labor volume can only be maintained with an annual net immigration of 400,000 workers until 2035. And this is really a structural problem. So the large inflow of refugees from Ukraine, but also from other asylum seekers from other parts of the world won't really change this. Of course, we can talk about whether there are instruments to address that asylum seekers and other migrants who are in Germany can already can get into education in the health sector, but I'm not focusing on that. I rather would go on and say that of course, we know in the health sector also that there has been so much internal EU migration But if we look at the demographics of other EU member states, we see a demographic transformation that goes into the same direction as Germany. So we'll see much more recruitment from other countries outside of Europe, and also developing countries, of course. I won't talk too much about the reforms, but give you on the next slide a really short impression of what the law will look like at least. This is the proposals from the government. Of course, Parliament can always change things, but this week they will present their new immigration reform. But before saying that, I just wanted to say that I would maybe differ a bit from the introduction and say that there has been gradual reform over the last 20 years. And 10 years ago already, the OECD said that Germany had the most generous rules for highly skilled workers, but it never really translated into the desired recruitment of skilled workers from abroad. And now, recently, there was also OECD attractiveness ranking where Germany lost some of its attractiveness with regards to highly qualified professionals. Sorry. So going to the next slide. Oh, I'm already on the next slide. There will be 3 different pillars. I don't know if that makes it much more easy to understand. The idea of migration experts is always to make the rules a bit more transparent and easy to understand, but somehow that never really works in Germany. So we have 3 pillars. And the first pillar is really the skilled labor pillar that we already have had under the last government in the last 3 years. There's not much difference in comparison to the rules already existent. Maybe just that the employer has a bigger say or agency in judging whether a potential employee qualifies for the employment, and then he or she can immigrate. And then there's a second pillar, which is the experience pillar. I think that is probably a crucial change, because in future people might be able to immigrate before having a formal recognition of their degree, if they meet certain requirements, including the permanent employment contract, or at least 2 years of work experience. Of course, that still, has to be somehow testified. So we'll see how that works out in practice. But this is certainly something that could lead to a larger number of immigration, rather maybe than the third pillar, which is kind of a tribute to Canada, because it's basically also a point system in addition to all the other things that we already have. And it's called the Opportunity Card, a point system based on professional qualifications, German, maybe even English. That's not clear yet. That was something that was in debate between the parliamentary groups, because of course German language knowledge is always a big hurdle, a big challenge to really a lot of people who might be interested to come. Work experience, age, and other aspects as well. This is if you qualify with a certain number of points, you would be allowed. So I think that's also a difference from the Canadian model to initially come for 1 year job search and trial employment, and then maybe there's a way to make your stay permanent. And this is the official 3 pillars. I would add another half pillar, so to say, which is also in the reform proposal. I don't know the details yet. I only saw a draft, So I'm not sure, but I think we're also going to see more low qualified labor coming through to Germany. This is often being referred to as the Western Balkans regulation, and at the moment this has been in practice for 5 years, and the annual quota should be increased from 25,000 to 50,000 people who could come for temporary employment and through quota system as well. We'll see if there's other appetite to add other countries to the list. It would be easy to do that, but so far the Western Balkans are the only region or the only country that is that has such a scheme. Okay, I think going to the next slide. Of course, you can have the nicest labor rules on paper, yet a lot of structural challenges are something that labor migrants and health workers that want to come to Germany are confronted with. And those structural challenges we write a lot about in the study that we published today, and also have some proposals how to address them. Just briefly mentioning maybe the most important ones. Of course, a lot of people are digital natives, and digitalization in Germany is very slow. And if you want to apply for a visa and also maybe get information about Germany, maybe even get your qualification recognized, this is extremely challenging, and digitalization here is not that progressed yet. Another big challenge is the administrative infrastructure, because we have mostly local foreigners, so-called foreigners authorities. Some states changed the name into immigration authorities, but the foreigners authorities are really, they also have some word to say whether a person is allowed to immigrate or not, and often those tasks, they interpret this task more as a doorkeeper than really a service provider, and they're hugely challenged also with other tasks, such as working on asylum cases, and also in the context of Ukraine, the Ukrainians coming to Germany, they don't really have enough men and women power to work on this. And also the welcoming culture is, as Felicitas pointed out, something you won't find in those places. So I just very briefly show this map. You can already, if it's too complex, our experts here, editorial staff told us not to print this, but we did print it, because this is basically a map. We hadn't seen a map where all the state structures are can be seen, and you see how complex it is. You see that a lot of federal ministries are involved, especially also health ministry was very involved in the most recent years. But a lot of the knowledge is actually on the level of implementing actors, such as the Federal Employment Agency, the German Agency for International Cooperation. They are really the ones that have experience for more than 10 years in developing fair migration policy programs, especially in the health sector, with countries such as Vietnam. And I think this has to be kept in mind when we talk about, what can the state do? And we also address the question in the study, what where are non-state actors much more important or more relevant because they're faster, cheaper, and so on. I know that Felicitas and Margaret, you worked on this, so I'm not going to say much more about this. Maybe that's something for the debate or other presenters. Moving back to my presentation. I briefly want to mention Germany's recruitment experience with fair recruitment. Sorry, that's too fast. So far there's no whole of government approach in this field. So when there's a list of countries to really cooperate on and to maybe also agree on a recruitment scheme, recruitment agreements. This is something that is being done by the Federal Ministry for Labor together with the Federal Employment Agency, and then they cooperate. They have a list and also, of course, some ways of coming up with a list of partner countries, and the development policy sector is not very much involved in this matter. So in an ideal world, we say, fair recruitment would, for example, include global skills partnerships, or would follow the example of global skill partnerships, and invest also in education systems for health workers, for example, if they want to recruit health workers, and maybe even develop a joint curricula. There are some examples. Most pilot projects are implemented by the GIZ. For a more detailed overview, again, please have a look at the study. And yeah, there's one decade of experiences in this, and most projects never went beyond the pilot phase, because it's too demanding, too expensive, too difficult to implement, especially in the initial phase. One exception is maybe the GIZ Triple Win program, which has existed since 2013. I think Felicitas, you wrote a bit about that in your joint article, and would be interesting to look at why they were successful. Initially, it was state funded. Now it's private, the private sector that took over. I think hospitals mostly, and we in the study recommend scaling up programs like these. But of course, the question's also there, what kind of financing mechanism would work? I'm curious to also hear maybe about Canada's instruments in this field. What role do employers play? Also, especially with regards to fair recruitment, oriented at ILO's and IOM's instruments and criteria in this field. I would stop here. I'm happy to discuss more, but I also don't want to be too long. Thank you.
Thank you so much, David. And this is precisely why we do this webinar. We have very little comparison between the two countries. And I'm very glad you showed the chart on that, because I was presenting last week at the Metropolis conference in Canada, and I had a similar chart I came up with just to understand how things work. So thank you for that, and also bringing in the fair migration. And because we have to ask if the gold standard doesn't also apply or asked for a fair migration model in a way. And I haven't heard that so much about Canada. But our colleagues will speak about that. I now want to ask Maria. She's working since many years on healthcare workers in Germany. And what do you see, what is going on the ground? So that, Maria, please, the floor is yours.
Thank you. I would like to speak about the results of a project I have done with colleagues in the Institute for Social Research and at the University of Frankfurt. And it was about recruitment and autonomously migrating nurses. So I will keep on the recruited people. The recruitment from in this last phase, I mean, previously there have been also recruitments in abroad, but since in 2010, the recruitment started again much stronger, and we had especially in the southern European countries where there was the austerity policies, and later also to Eastern European countries and ASEAN and even Mexico. So in this project, we had interviews with people from all these places. What I find interesting is to confront the ethical principles of the recruitment with the realities we have found. And shortly, the ethical principles refer to the relationship to the three parts that are involved in this recruitment process, meaning the countries of origin and promising a fair recruitment, and analog to the principles fixed by the World Health Organization in the Global Code of Practice, and secondly, protection of the recruited nurses, the professional and social integration, and third, transparency and reliability for the recruiting hospitals and care organizations. So this is what also is in guiding the triple win project that is making the recruitment today abroad. The main idea is that we can see that there is a lot of problems to find a fair recruitment, a lot of problems to find a sustainable integration, and so on. So I will start with the main point that is the point of the skilling. Nurses in Germany is a regulated vocation, and a prerequisite for working here is to be registered as a nurse, to the recognition of the equivalence of the qualification acquired abroad with the German one. So the Recognition Act adopted in 2012 regulates these recognition procedures. But generally important is that the nurses' education and nurses' work in Germany and in some of the countries of origin are quite different. In Germany, the work of a nurse so far is practically oriented, involving work on the body, while curative activities are exclusively assigned to the physicians. And so is nurses' education a non-academical, offering practical skills base and emphasis on the handmaiden relationship with the physicians. On the other hand, in many other countries, nurses' education is an academic training offered by universities. Education covers also aspects of medical science. So the equalization of the academic degree to a non-academic degree seems to entail a paradoxical simultaneity of recognition and evaluation of skills. The skilling on the one side and formal permission to do the job in Germany on the other side. Our interview showed also that the recruited nurses were not aware, they seem not to have been informed about this difference between the country of origin and German work conditions. And if they have been told about it, it seems that it has not been in an adequate way. In any case, they were surprised and frustrated. They experienced damage to their professional identity and the loss of prestige in relation to their former academic position in the country of origin. So this difference in the between academic versus non-academic credentials and the devaluation of their own skills is in the core of the integration dynamics, which are also disintegration dynamics. And here we could see that nurses educated in Germany, these are not Germans, these might be also migrants. So nurses educated in Germany demonstrated distrust towards the academically educated newcomers. The initial difficulties of the recruited nurses in fulfilling the new works they have to perform make them believe, make those educated in Germany believe that the newcomers are incompetent and despite their academic credential. On the other hand, recruited nurses interpret the stance of the nurses educated in Germany as a racism. So fragmentation, tensions, and conflict are the consequence, what we found out. However, under the pressure to do the work and maintain daily work routines, the recruited nurses make efforts to cooperate and carry out their duties despite hostility and resentment. In the workplace, a kind of pragmatically motivated integration takes place. This, however, is not sustainable and cannot be maintained for long. So one of the coping strategies, the main coping strategy, I would say, is exit. The nurses seek to transfer to another unit or organization, or they want to leave Germany at all or go home, back home. Germany then becomes, despite policies aimed at long-term residents, it becomes a temporary destination. And internationally recruited nurses frequently intend just to move forward. So I think in this form, we can see that disintegration and the pragmatically motivated integration at the same time, as well as the exit, as the characters of the social field. Now, concerning the protection of the health systems in the countries of origin, is this fair recruitment? The German government claims to respect the code of practice decided by the World Health Organization, and which foresees that, recommends that that in countries where the health system is suffering from a serious shortage of health personnel, there should not be recruitment of international nurses. And these are 57 countries listed in this global code of practice. From a quantitative point of view, the proportion of nurses in Germany are much higher than the proportion of nurses in the countries where recruitment takes place. And during the pandemic, we have seen also conflicts, so that some countries like Serbia and Romania decided that their medical staff shouldn't get recruited anymore. Serbia has an recruitment agreement. This has been cut down. Romania is a European unity country, and despite this, the Romanian government tried that medical staff doesn't get out. And from the other point of view, we see that those who recruit, they try to get the highly qualified, the academically qualified, although Germany needs low qualified nursing. So I would say that there are many points that show that there is a loss of human capital that shouldn't be, and that is not a fair recruitment made, which has to be discussed further, of course. But concerning the de-skilling and the future, I would like to mention that in the year 2020, there has been a new law concerning the education of nurses, and this foresees that academically education for nurses should also take place in Germany. So there are some universities for applied sciences who already have started with this studies. But the question is if this will help those who are recruited in a position, let's say, to be also recognized as academically educated, because there will be such a degree in Germany. This is open, I would say. The time we will see in the next time how it will have an impact on the situation. So I will stop here. Thank you very much.
Thank you so much, Maria, for shifting our attention to processes of de-skilling, which go along with having nurses from other countries to Germany, and on shedding light that there are exit strategies of those who are already here, which is a disaster, because if we bring people in and then allow or just let go, that is a problem, I would say. So those sorts of disintegration. But I'm curious to hear what is going on in Canada. So I would hand over to Ivy. We are running a bit late, but that doesn't matter. I mean, we have a bit of time afterwards also. Thank you, Lynn.
Wonderful. Thank you so much. I'm hoping that you can see my slides okay. So I want to really build on the presentation that David and Maria have made and sort of map that against the context in Canada. So really trying to tease apart the migration, licensure, and integration processes. So, in a nutshell, health worker migration, licensure, and integration are complex and expensive processes in Canada. So we make a case that we need to really tease apart these three different processes. And in the Canadian context, we lose people represented here by these water droplets. And this is a visual that was prepared by a postdoctoral fellow, Hussam Benamin, who was working with me. So each step in this process involves a complex web of stakeholders, and this really picks up on that last slide that David shared with us. So different stakeholders, different processes at the national, federal, provincial, territorial, and then local municipal levels. And it's really important to kind of tease apart those different stakeholders and to understand the different policy communities involved in this process. So if we start first with the immigration process, this involves both governmental, largely, and some non-governmental organizations. So outside of Canada, the process starts with consulates and embassies, representatives there who may or may not be familiar with the next steps in the processes for migrating health professionals. It also includes recruiters and intermediaries who may be both formal and informal. So families and cultures of migration are something for us to consider. In Canada, our federal government and immigration is largely influenced by IRCC, so Immigration, Refugees and Citizenship Canada, but it's also impacted by other ministries such as Employment and Social Development Canada, could also be Health Canada. So as David outlined, there are a variety of different ministries involved, particularly when you're looking at migrating health professionals. And then you get to the layer of provincial and territorial governments. And in Canada, we have a very federated health system. And so that is quite distinct. But just to hold that thought for a moment, immigration is at a federal level. However, for some provinces, like the province of Quebec, they've negotiated special arrangements because of their unique Francophone context, but also other provinces are negotiating different types of agreements. So they have ministries of citizenship and immigration, and they have also enacted provincial nominee programs. So provinces and territories are becoming more active in the recruitment and migration. And then at municipal level, so at a city level, there exist a number of different settlement organizations who really try to kind of pick up where people are lost in between those various cracks between these policies. So there's a number of challenges here. There's often unclear and inconsistent information. There's the requirement for numerous documents to go through the immigration process, and depending on which pathway, and there are increasingly more pathways beyond just you are the primary applicant and you get points. There's family pathways, there are student pathways, there are temporary migrant pathways, there are refugee pathways. And so each of those different pathways requires different documentation. This can be very time consuming. That has exacerbated during the pandemic. And there's a lack of transparency in terms of where you are in the queue. People say I'm in a queue, but that queue, there's no sense that you have, 20 days, 20 months, 20 years, if that's how long it's going to be. So, some high-level solutions, providing more consistent information, streamlining the documentation required, accelerating processing times, and increasing the transparency. Those all sound very simple, but they are very complex solutions to implement. So that's immigration. If we go to the next stage about licensure and processing, that's another different web of stakeholders. And what's interesting is that these web of stakeholders often don't interact with the previous web of stakeholders for immigration. And so lack of joined up policies and processes are important. Here we primarily see non-governmental professional organizations. So licensure, depending on the profession, may require some credential recognition happening outside of Canada. And for medicine and nursing, there are some elements that have been offshored to the United States. For nursing, there's the NNAS that's based in the United States. So they process, recognition of initial qualification for medicine happens through the ECFMG in the United States. However, in the case of medicine, there are national level examining bodies. So there are exams that are within Canada for medicine. In nursing, those exams are based in the United States, the NCLEX exam. And there's a variety of different other processes for different other health professionals. The main stakeholder organization here are the provincial and territorial regulatory authorities, what we call colleges in English Canada, or orders in Quebec. So they would be similar to boards or councils. So they are the regulatory authorities, and they have a set of processes which map onto some national level bodies, such as certifying bodies, and as well as, what they need to, types of documentation that they need to produce, and negotiate those with outside of Canada organizations. And then here too, at the municipal level, you see a lot of settlement organizations trying to provide support for for the licensure process for different professionals, different types of solutions that they have there. So here too, the licensure process, which is quite distinct from and separate from immigration, costly, complex, time-consuming. There are capacity challenges within the system that cause systemic delays. There's sometimes obscure language requirements that may not be profession specific. There are the examination costs, and someone can go through all of the exams and still not make it into the system because there's a bottleneck at the level of, in the case of medicine, for example, the residencies, or as Margaret was mentioning at the outset, we need to have some type of oversight, and that requires capacity within the existing system, and that system is under a lot of duress. And then there are family and financial constraints, and in earlier research that we undertook, gender really matters here. So if you migrate as a family, it's typically the male, quote unquote, head of family that will go first for licensure process. You know, because somebody in the family needs to make money. And so typically women within partnerships come later, and therefore the recency of their practice is much more tenuous. So solutions here is to streamline the registration process, applying through one portal or gate, and making sure that those policies are lined up with the immigration policies, reducing fees and increasing timeline and system capacity, facilitate access to formal and informal assistance, and provide financial and other forms of support. And I think Carolyn will speak to a really interesting program in Nova Scotia that's really trying to build on some of these solutions. And then there's at the employment level. So once you get your license, that's not the end, because typically employment processes and landing in the right position can be quite challenging. So here too, we have primarily non-governmental organizations. They could be employers or employment agencies. Whoops. And what we find here is there could be stigmatization, bias, and discrimination. Even if someone has English, if they have English with an accent, there's a stigmatization with that. There could be linguistic challenges that could also be professional or sector specific. There are often cultural misunderstandings and a lack of familiarity with the Canadian healthcare system. So there's a need for integration, bridging types of programs, but bridging programs in Canada are incredibly vulnerable. They often don't have sustained funding. And so some solutions are supporting a culture of civility, free of discrimination within healthcare settings. And I think Felicitas mentioned at the outset, you know, we still have a lot of racism within our system. And anti-immigration as well. So providing orientation programs to facilitate the integration of internationally educated health practitioners within various workplaces, that requires capacity of those who are in those workplaces. And we haven't traditionally supported that. And providing support for mutual recognition and awareness, because internationally educated health practitioners bring knowledge that we often don't tap into effectively. So coordination here is paramount. This is a book by Mark Britnell, and it was published in 2019 when the projections for the shortage of health workers was 18 million by 2030. That has only exacerbated, and Maria has spoken to these issues. And so he made this case, it's possible to make good this gap in the shortage of workers by orchestrating policies and practices in a more innovative, concerted, and collaborative way. And it will involve the determined, careful coordination of many different agencies, institutions, and organizations, which by design, their goals are to do different things than coordinating the pathways for internationally educated health practitioners or coordinating pathways for health workforce policies more generally. So just to remind you, and Maria raised this issue about the guiding principles of the 2010 WHO code, ethical recruitment, discouraging active recruitment from developing countries facing critical shortages. And Maria mentioned 57 countries that were highlighted then. That list is updated and needs to be updated since 2010. You know, that's a number of years ago. And I wanted to highlight two other ones because it's really about what Canada should be doing in order to have systems that are more sustainable to integrate internationally educated health practitioners who are coming here, but also to create much better planning so that we are not left to actively recruit because we're always in a crisis. So countries should implement effective health workforce planning, development, and sustainability strategies. And number 6, we're encouraged to gather data towards planning. Earlier this year, the federal government announced, so our federal government collects taxes and then they provide funding to the provinces for healthcare. And there's always a very interesting political dance in that regard. So as part of this package of how the federal government was to provide funding, increased funding to the provinces for healthcare, particularly in light of the destabilizing impact of the pandemic, it announced that it would create a Center for Excellence on Health Workforce Data. I'm very pleased to say that the name is going to change to Center for Excellence on Health Workforce Data and Planning. And that has been a lot of different work. So that's the federal government. We also have a House of Commons Standing Committee on Health. That's all parties. And that's not just the governing party, but all parties looked at Canada's health workforce. There were 22 recommendations that came out earlier this month. And the first 4 are really about international recruitment. And so I think that we have in Canada a number of internationally educated health practitioners who are not effectively integrated. Some of those are more easily integrated than others. But in a document that was specifically about Canada's health workforce, that the first 4 recommendations were really about internationally educated health practitioners. So I want to just pick up on recommendation number 1, to recruit from countries known to train health workers in excess of their domestic needs. And there's a whole reason for that. So this is pre-pandemic. And so our one province of Saskatchewan signed a bilateral agreement with the country of Philippines. And it was presented as a win-win situation. But when you actually looked at the data, and data that are, very blunt and somewhat problematic, provided to population ratios, but even using those very, very blunt and often inaccurate measures, Philippines ratio was 1.7 to 1,000, and that was considered oversupplied. Saskatchewan had an undersupplied ratio that was 6 times as much. And so this was pitched as a win-win. And I would argue that just based on the math, it wasn't. And so there are also concerns that have been raised by the International Confederation of Nurses, that internationally the nursing workforce is in crisis. The pandemic has exacerbated that. And many low and middle income countries beyond the 57 that were listed in 2010 are in a state of crisis, a crisis that is much larger than the crisis that we are experiencing. And so one of the things that they called for in this, and I'm curious as to whether or not this will come up in the global forum in a couple of weeks, there's an urgent need to really look at measures of self-sufficiency, which was one of the principles of the Global Code and also one of the principles of the Global HRH strategy from 2016. This notion of a self-sufficiency index, which can flag how reliant countries are on international flows. Let me just say, I don't think Canada would do very well in that type of thing. So take-home messages here: high-income country like Canada should dedicate more resources towards planning and management. And Margaret had put up, we made the case that 8% of Canada's GDP is the health workforce, and they haven't really been planning with that type of economic measure in mind. It's not in the spirit of either the Global HRH strategy or the Global Code to rely on active international recruitment. I think that there are nuanced differences, and I think Carolyn will speak to those nuanced differences. And that planning requires more than data and modeling. It requires a shift in our culture towards embedding cycles of planning so that we are less reliant on international recruitment. Now, this, again, there are different migration pathways. And as Felicitas, you highlighted before, pathways around refugees, although Canada seems to be such a welcoming country, we numerically, we do less so for refugees. So those who are in refugee camps, I think, are a really important resource that we should think about in terms of sustaining and enabling their ability to practice. So with that, I will stop and pass back. Thanks.
Thank you so much, Ivy, for your very quick but very rich overview on the leaky pipeline in a way, which we heard of from Maria also. And also David was speaking about that, many institutions at stake, no clear competences, but then coming up with the idea or with the expectation to have a planning institution within that. So thank you so much. I hand over to our last speaker. She has also 10 to 12 minutes. Thank you. Caroline, please.
Perfect. I hope you're all seeing this presentation now. So hello, as has been introduced, my presentation today will provide an example of a provincial initiative being undertaken in Nova Scotia to support the integration of internationally educated health professionals into health systems and communities. I'll begin by providing a brief overview of the challenges experienced by internationally educated health professionals in their pathways to licensure and employment in Canada and other destination countries, and then describe Nova Scotia's International Community of Healthcare Worker Engagement Program, or NICHE, which explicitly aims to address these barriers to integration. I'd also like to acknowledge that I'm presenting on behalf of a very large and dedicated team of individuals involved in the implementation of this program, which is sponsored by Nova Scotia Health's leadership team and led by Dr. Gail Tumblin-Murphy and Dr. Tara Sampali. Oh.
No, fine.
Perfect. So longstanding shortages of health professionals have been exacerbated by the COVID-19 pandemic, leaving Nova Scotia, like many other jurisdictions in Canada, in a state of crisis that is significantly impacting the health system's ability to deliver essential care services, especially in rural communities. Despite increasing levels of need, through the evidence syntheses that we've conducted and direct engagement with internationally educated health professionals, Nova Scotia Health identified a number of persistent challenges that were preventing the optimal integration of IEHPs into Nova Scotia and across Canada. So first, IEHP struggled with navigating complex licensure processes, with limited access to clear communication and guidance. Furthermore, these processes were characterized by significant inefficiencies and undue burden imposed on IEHPs as a result of disparate documentation requirements across immigration, regulatory, and employment organizations. For some, the burden associated with collecting this documentation was amplified due to variable access to required documentation, depending on the circumstances of their migration, as well as the regulatory infrastructure in their country of origin, introducing significant inequities within the IEHP community. For others, navigating the licensure process in a federated system was complicated by the lack of coordination, harmonization, and recognition across provincial level regulatory processes. In addition to challenges associated with navigation, many IEHPs experienced temporal and financial challenges in their journey to licensure and employment. First, the timelines associated with numerous steps in the credential assessment and recognition process can be very long, introducing significant delays and attrition in the IEHP's integration process, during which time their skills cannot be optimally used and their currency of practice within the profession declines. Furthermore, immigration, credential assessment, education and training, examinations, and licensure processes are costly, imposing significant financial barriers to integration. And finally, due to the length and cost associated with these processes, many IEHPs face significant challenges completing required education and study while working to support themselves and their families. Within extant literature, a number of promising practices have been identified to address common challenges associated with the integration of IEHPs. So first, significant differences in the experiences of those who have investigated and or initiated the credential recognition process prior to immigration highlight the value of pre-arrival supports and early system navigation programs. Second, bridging and workplace integration programs have been proposed as an effective means of addressing gaps in IEHPs' education and competency profiles, and to increase their familiarity with the context and configuration of care delivery in destination countries. Third, given the ethical implications associated with international recruitment of healthcare professionals, particularly when high-resource countries are recruiting from lower-resource countries, it is best practice for destination countries to abide by the WHO Global Code of Practice on international recruitment of healthcare personnel, as has been identified by a number of our presenters today. With this evidence in mind, let us turn our attention to the context in Nova Scotia. So Nova Scotia is an Atlantic Canadian province with a population of approximately 1 million residents. The province is actively seeking population growth due to an aging population and has recently established an Office of Immigration and Population Growth to support these efforts. Much of the healthcare services in the province are delivered by Nova Scotia Health, a single provincial health authority that operates hospitals, healthcare centers, and community-based programs province-wide. Nova Scotia Health and other healthcare employers across the province are experiencing significant workforce shortages and high vacancy rates across multiple health professions, including nursing and medicine and continuing care. While every effort is being made to develop, optimize, and support our domestic workforce, leveraging the untapped capacity of internationally educated health professionals currently residing in Nova Scotia and elsewhere has been identified as an opportunity to address critical barriers of access to care within the province. As a result, the niche program aims to develop a comprehensive, ethical, streamlined, and sustainable pathway for the recruitment and retention of internationally educated health professionals to improve access to care in Nova Scotia. This vision will be achieved through targeted activities across 5 key objectives. First, the niche program will establish ethical and sustainable recruitment and immigration pathways for internationally educated health professionals. Second, the niche program will develop streamlined pathways to licensure and deliver associated education and training supports to recruited professionals. Third, the niche program will enhance community and health system preparedness for successful integration of recruited professionals and their families. Fourth, the niche program will provide comprehensive settlement supports for recruited professionals and their families. And finally, the niche program will provide transition to practice supports to recruited professionals to enable sustained service delivery in innovative models of care. Through rapid cycles of health system learning and education and evaluation, the program will also generate evidence-based practices for the integration of IEHPs, enabling knowledge sharing and learning opportunities to inform scale and spread across the province and nationally. By focusing on both community and health system integration in parallel, this program is seeking to bolster the sustainability of its recruitment and retention strategy. The program activities are designed to enhance the preparedness of Nova Scotia's healthcare settings and communities to serve as welcoming and inclusive environments for the successful integration of internationally educated health professionals. Positioned within the Health Innovation Hub, Nova Scotia Health is implementing the niche program in collaboration with a diverse array of both internal and external partners. Within Nova Scotia Health alone, the implementation of this initiative requires meaningful and continuous engagement with teams across the organization, including the Health Innovation Hub, Interprofessional Practice and Learning, Medical Affairs, People Services, Zone Operations, Occupational Health and Safety, Communications, and IT. Beyond Nova Scotia Health, Niche's implementation has involved close partnership with government departments, including health and labor skills and immigration, domestic and international academic institutions, regulatory bodies and unions across multiple health professions, and community partners with the capacity, experience, and expertise to offer settlement services, including the Immigrant Services Association of Nova Scotia and the YMCA Y-Reach program. In line with the principles of ethical international recruitment outlined in the WHO Code, the niche program is also establishing partnerships outside of Nova Scotia to enhance global nursing and healthcare workforce. As early as a few weeks ago, a delegation from Nova Scotia was traveling to India and the Philippines to establish strategic and mutually beneficial partnerships with colleges of nursing to create student and faculty mobility pathways. These pathways will involve the delivery of orientation and transition to practice pathways in partnering countries and as a part of the colleges of nursing curricula within their global health mandate. Furthermore, the partnerships with the colleges will also extend to fostering collaboration across research and innovation. Working with partnering colleges, NICHE will support those who have already decided to come to Nova Scotia through fully sponsored pathways, offering comprehensive support and an ethically sound approach. To date, the NICHE program has been able to develop key structures and supports that will serve as the foundation for the scale and spread of this approach, including developing the requisite data infrastructure through the development of a comprehensive assessment and intake survey, developing the requisite communications infrastructure to interact with candidates, including the creation of a welcome website, central inbox, and weekly newsletters, establishing a welcome team, including community liaison positions, community professional mentors, and community support programs and services, which include language proficiency supports, developing immigration and settlement support pathways in partnership with relevant immigration authorities, and developing sponsored pathways to licensure and associated educational and transition to practice to supports in partnership with regulatory bodies and educational institutions. Beyond the fulfillment of the objectives I've already mentioned, the NICE program is anticipated to achieve a number of wider impacts. First, at maturity, the program will serve as a center of excellence, generating open access data and toolkits available through cloud-based platforms to enable knowledge sharing and learning for researchers and policymakers. Namely, the lessons learned and promising practices identified through the implementation and evaluation of the NICHE program will inform the development of an open access IEHP integration toolkit, offering a variety of resources, tools, and services to other Canadian communities and health systems seeking to support IEHPs in their journey towards licensure and employment. The program will also serve to enhance health system performance in Nova Scotia by providing contributing to the development of a workforce that is better aligned with population health needs, thereby enhancing access to care in areas of need, reducing wait times, increasing efficiencies, and reducing the costs and unintended consequences associated with waiting for care. Finally, the program will serve to enhance patient and provider experience by bolstering the integration of skilled professionals and their families, enhancing equity, diversity, inclusion, accessibility, and representation within the health workforce, and improving the psychological safety of our work environments by addressing staffing shortages and moderating workloads. I'd now like to conclude with some reflections on 4 key lessons learned to date in the implementation of the NICHE program. First, it's clear that health systems have a critical and ethical imperative to support the integration of internationally educated health professionals, and it's no longer viable for these settings to underutilize the wealth of knowledge, skills, and expertise at their disposal within the IEHP population, particularly those who already reside within their jurisdiction. Second, direct engagement with internationally educated health professionals is key to developing pathways that address the existing challenges and are responsive to the needs of IEHPs. While the literature can offer some insights into the challenges faced by IEHPs, challenges raised during community discussions we've hosted have been much more informative in the development of enhanced pathways. Third, coordination and communication across a strong and eager network of partners, including government, regulatory bodies, academic institutions, community partners, and health system partners, guided by a common vision, is critical to innovative and timely action. Mobilizing a coalition of the willing allows for a shift from asking, can we do this, to what do we need to get this done? And finally, given the pace at which progress is required within health systems at this time, adopting a learning health system approach guided by a robust mechanism for evaluation can allow for timely and iterative implementation of innovative solutions. Overall, while this work is a case study in the complexity of the health workforce and the global network of health systems they uphold, it is incredibly rewarding, and we are incredibly excited about the opportunities that this will create for internationally educated health professionals in our province. I look forward to discussing this work with my co-panelists.
Thank you, Carolina. Thank you for sharing those informations with us. Thank you so much. Also, I think we have a very timely webinar here because it's all done in these weeks, what we see, based on what has been done before, of course. I mean, you were speaking about ministers traveling to other countries, looking after the curricula. We have the same here. We have traveling ministers to Canada in that case to learn from the Canadian example. I think that is very exciting. So our webinar is very timely. I would like to give the floor for a moment, maybe to all speakers, what they learned from the other speakers, and then we open for the audience. Margaret, what do you think? Is that good?
Yeah, and I apologize. I have had some internet trouble, so I've been dropping in and out. But what I heard was great, and I was really appreciative for all of the presentations. I mean, it raises questions for me in terms of it's fascinating to think about the educational differences. I think Maria's focus on the differences between how German nursing as an education, as a profession is perceived compared to where migrants are coming from is really a fascinating consideration. Ivy did a very nice presentation illustrating the complex steps along the way in terms of the immigration recognition and integration. And I think that contrasted well with David's interesting analysis of most recent legislation changes in the German context. And I think this is again indication of those policy levers have been shifted by consequences of a pandemic. And Carolyn's presentation, thank you so much. I was very interested in that. And again, it raises all sorts of interesting issues, especially how do we perceive ethical? There are different ways of achieving what we might think of as an ethical model. But more importantly, I think, is the focus on looking at internationally educated health professionals integration as part of a health systems approach and as part of a learning health systems approach. I think these are really fundamental issues, and so I very much appreciate the panelists raising them for our consideration. Thanks.